Welcome, everyone. I'm Denny Brennan, the Executive Director of the Massachusetts Health Data Consortium. And I want to welcome you to today's webinar entitled How Health Systems Are Leveraging Health Information Technology to Improve Their Performance, Lessons from 24 U.S. Health Systems. Today, we will review and discuss the ways in which healthcare is increasingly delivered through integrated health systems that consist of multiple hospitals, medical groups, and physician practices. These complex organizations are engaged in a range of activities in respect to improving their performance with health information technology, and some are far more advanced than others. In this webinar, you will learn findings from a large study based on interviews with executives of 24 U.S. health systems. We will discuss the key health IT related activities that are common across health systems, which activities require substantial investment and strategy, and which characteristics of health systems define those that are more or less advanced in succeeding in these activities. Key points covered today will include the following. 1, identifying the key activities U.S. health systems are doing to leverage health IT to improve their performance. 2, understanding the wide range of health systems progress within these activities. And 3, discussing approaches to help further support health IT and health systems to better leverage health IT. Now let's go over a few details about today's webinar. It is 120 minutes in length. This will allow for approximately 80 minutes of presentation and 30 minutes for questions and answers. The Q&A session will be held both in the middle of the presentation and at the presentation's conclusion. Today's program is being recorded and will be available on the MHDC website a few days after the session. We have listed here our social media contact information and encourage everyone to engage in the dialogue on these platforms both during and after the presentation. Attendees today are participating in listen-only mode, and using the questions pane on the screen is the way to interact with the speaker and have your questions presented as we move forward. If time does not allow us to answer all the questions you have today, your questions will be forwarded on to the speaker, and we will do our best to follow up after the session so that we can post your answers on the website. We will be launching also 2 polling questions today, and we hope that you will participate in this interactive measurement tool. And finally, as you exit the webinar, an electronic survey will appear on your screen. Please take a moment to complete the survey. It's extremely helpful to us, and it enables us to measure your satisfaction with respect to today's presentation. Your feedback is really important to us. And now it is my pleasure to introduce today's speaker. Dr. Robert Rudin is a senior information scientist at the RAND Corporation. For more than 15 years, he has conducted digital health research with the aim of illuminating user and stakeholder perspectives and improving their use of health information technology. These improvements are achieved through better technologies, improved implementation approaches, and improved policies. He has worked closely with healthcare professionals and technology developers and takes into account their socio-technical contexts to develop and evaluate scalable solutions. Prior to joining RAND, Dr. Rudin worked as a software engineer and earned a PhD in technology management and policy at the Massachusetts Institute of Technology. Welcome, Robert.
Thank you, Denny, and it's a pleasure to be here today.
We have a lot to cover today. So I'm going to put myself on mute, and I am going to turn the presentation over to you.
Great, thank you. I'm very much looking forward to sharing some of the findings from our research and engaging with this group. And thanks also, Denny, for all your work with the Massachusetts Health Data Consortium. So I'm going to start with an observation, and that is that life has transformed quite a bit because of digital technology in many different ways. So here's just a few examples. Banking, or the way we conduct banking today, is very different from the way it used to be before ATMs, and it's continuing to transform and revolutionize with mobile payment apps, Venmo, etc. The way we conduct banking online, everything, it's all been enabled by software, digital technology. Transportation, back in the day, remember, we needed to go to travel agents. We don't really need travel agents anymore. It's all been automated for the most part. And ride sharing, talk about increasing access. That's really been quite transformational. And probably even more so is with communications. Just having us be able to have this webinar wasn't really that long ago, within our lifetimes, where we needed to make phone calls long distance and actually pay for them and keep track of our minutes. And now we talk with video calls that are pretty good quality across the world, and you have to pay for the basic infrastructure, but you don't have to pay per minute. So that's been quite revolutionary in many industries. Not as much in healthcare, unfortunately, and this is not for lack of trying. So we all, I think, probably in this group know about the High Tech Act and meaningful use, and I think it's probably more than $27 billion, depending on how you count it. Now, the intent of this was not just to adopt technology. It was this quote here. This is from David Blumenthal, writing in the New England Journal, saying the goal of this is an investment to improve the health of Americans and the performance of their healthcare system. Now, we did, during this last 10, 15 years or so, see a major increase in use of health IT. Electronic health records, e-prescribing, CPOE. During the pandemic, we saw a pretty big increase in telehealth. It's true. Some might say that was transformational. We'll see how long that persists. But I'd argue a lot of in terms of the type of transformation that we were really hoping to see, which is key performance metrics, we haven't really seen that transformation. So there's a lot of studies that you can look at that all mostly say the same thing, and that is the U.S. is still not ranked all that highly among comparable countries on measures that we care about. So quality, outcomes, and certainly cost has not decreased. There hasn't been cost efficiency. The value equation hasn't improved. So we set out to answer a couple questions in this study that I'll be drawing on mostly. And the first is, why isn't this change occurring as rapidly as we hoped? And also, what could be done to accelerate progress? Now, one thing about IT is that just adopting it doesn't automatically lead to changes. And that's not just true in healthcare, it's true across the board. This is a study some colleagues and I published in 2012 about the IT productivity paradox, which was first formulated outside of healthcare. Some of you are probably familiar with it. Others have written about this as well. And the just quick summary, essentially in the 80s and 90s, there was a lot of adoption of software and computers everywhere. But the economists were not able to find evidence that it's actually helping. So one of the Nobel Prize winning economists is quoted as saying, you can see the evidence of the IT revolution everywhere except in the productivity statistics. And eventually they were able to figure out what the problem was, and part of it was some measurement issues. Another part was some usability considerations, but a big part of it was that you actually need to change what you do to get the benefits. You can't just kind of throw in the technology and expect the benefits. And there's a nice example of this where in the early days when electric motors were invented, the engineers first said, well, let's just kind of plop them in place of the water wheels and have it centralized in one place. And didn't get too much benefits from that, and it wasn't until they re-engineered the processes and they put them in different, they had smaller wheels and put it more close to where the energy needed to be used. That's where they started to get new efficiency. So they changed what the processes are, and involved re-engineering what people did. So most of the rest of this presentation is going to be, and what I'll be discussing is based on some research we did that was funded by the Agency for Healthcare Research and Quality. This was done prior to the pandemic, but I think the lessons are still very much applicable today. This is the publication with my co-authors. I will say that if you're more interested in publications related to this, especially on health systems, and I'll say a bit more about that in a minute, there's the link to the website. There's quite a number of in-depth studies on very many different aspects of health systems. Now, we focused on health systems, and I think the next slide. Oh, let me just define what a health system is. So what we mean by this is integrated hospital and physician organizations. So not just a standalone hospital, not just a standalone physician organization, but integrated. So they can be vertically integrated, horizontally integrated, also have multiple different hospitals. And the reason we focused on this is because they represent the present and very likely the future of healthcare delivery, at least a large portion of healthcare delivery. So here's some numbers about that. Health systems, and the definition of health systems is not settled perfectly, but about half of physicians are working in some kind of health system, 3/4 of hospitals, 91% of hospital beds. So there's a lot of these out there. And I've tried to find out a count of how many health systems there are, and it depends on how you count them. There's no one place where you can go and get a registry of health systems, but in general, very rough ballpark, there's somewhere around 500 large health systems, and then maybe another 500 smaller health systems. That gives it some order of magnitude. Now, so what we did here is we talked to a lot of these health system leaders, and this is the interviews with the C-suite. We had a team of researchers. We interviewed. I'm going to be drawing mostly on the interviews with their CIOs or equivalent, and these are 24 health systems around the country in 4 different states: California, Washington State, Minneapolis, and Wisconsin. So, you know, this is a good sample of health systems. This by no means covers everything, but it's good for more in-depth understanding. Here's some characteristics of the health systems. You see, you know, mean number of hospitals zoned to 6. There's quite a range of physician organizations involved, and a lot of them had this clinically integrated network. Most of the health systems were Epic health systems, but we did have a smattering of others included in the study as well. Now, as part of this, we're specifically looking at how health IT was being used by the systems. Now, there's a tendency to want to measure like things that are more easily measurable, like what they are trying to do, like what they are doing exactly, like specific IT functions, like, you know, how many transactions are occurring or so forth. But to understand our research questions is like why this isn't happening faster, and what can we do to accelerate progress. Like, you know, we wanted to understand how, like that we thought would be a better way to get at the insights that we're looking for. So these are complex organizations, these health systems, and they're changing over time. They're growing, they're emerging. There's lots of acquisitions going on. It's been happening for a number of years. It's continuing. So we were looking more at like, you know, what are they trying to do to improve quality and improve their performance? What type of implementation strategies? What are their barriers? What type of contextual factors are being influenced and are they encountering? And this was we think a better way to answer that question of like, you know, why are we not seeing the type of performance gains than we are, rather than just kind of documenting the numbers. So we analyzed all this interview data, and I'm happy to provide more details on that process, but I won't go into that now. And in general, what we found is essentially that there were 3 categories of activities. One we're putting in, and I'm going to talk in more depth about each of these. We're going to put, I put one of them into this category of laying the foundation, these foundational processes, or foundational activities rather, to improve performance. The second one is using the IT to improve performance. So once you lay the foundation, you can actually do something with it. And then the cross-cutting category of making decisions about IT, and this gets into categories of governance, and that can, you know, those type of things can help with both laying the foundation and improving performance. So I'm going to jump right in and talk about the first category, which was most of the health systems were still doing to a large extent, and we'll start there. So 5 activities we found that that the data showed were foundational to, which didn't necessarily produce value in and of itself, but were needed in order for the health system to get to that next step. And those were making structural changes to IT platforms, standardizing their data and their analytic functions, such as their analytic departments, standardizing their care processes, including clinical protocols. And I'm going to go through each one of these in some depth. Configuring and enhancing your EHR, so not just, you know, installing it or making the structural changes, but tweaking it and optimizing it, and then maintaining a secure and reliable infrastructure. And I'll be touching on that briefly, but not too much. So let's start with each one of these. Now, for each one of these, I'm going to talk about characteristics of less advanced and more advanced health systems. And so now we tried as hard as we could to not put our own views into what less advanced or more advanced means. We let the C-suite, the interviewees, tell us what they thought were less advanced and more advanced. So like if they were saying that, you know, we're trying to get somewhere, then that's, you know, indicates that they had a clear view of what's less advanced and more advanced. And we had pretty, I would say, like pretty good consensus. Like we didn't, in cases where there wasn't a clear definition of, we couldn't tell what the less advanced or more advanced was, we didn't include that in here. So in general, we found very good consistency. So in this structural category, moving toward a single IT platform, it was viewed by pretty widely that it was advantageous. It could lower costs, enable easier upgrades, and can enhance standardization, which was an important other goal. So pretty much everyone was moving toward this unified single instance EHR. So the less advanced ones were still dealing with multiple vendors and instances. They were acknowledged that it was better to move to a single one. They were in the process of doing it. So one vendor, one instance was really the goal. And this is a breakdown of all of our 24 health systems and where they were in terms of their current structure and whether they were in transition or not. And I wanted to include this because it's just kind of interesting to walk through. So most of them were single instance and not in transition. They were in a stable state. And even them, it wasn't necessarily stable because, as some of the executives told us, there's this universal rule, which is as soon as you have some stability, you end up merging with another hospital or organization and then have to deal with all the work to make the decision. Do you want to maintain that separate as a separate instance or a separate vendor or merge them? And so it made and it would distract the leadership for a while if they decided to bring them on board, which they usually did, and focus on that instead of other activities. So, but most of them were stable. I did put this kind of interesting, there's this one that's a single instance that's in transition. We put that in there because they were going through a major upgrade, like from a product that they were using from the 1980s. So keep in mind, this is in like, you know, late 2010, so like 2018, 19 that we talked to them. And they, you know, they were upgrading from a 1980s product. So that's a big enough transition. All the other ones who were not on a single instance were making the transition, except for one. And I'll say a little bit more about that one. Why did it not have plans to transition? So this one was a health system that had a different EHR for inpatient, outpatient. They were tightly integrated, and they had, you know, they basically said it would be too much work, and they had already spent 10 years optimizing it. And they were continuing to just try to make their systems integrate as best they can, even though they knew it wasn't perfectly optimal. But they thought it was, you know, at the time the best decision for them right then. We haven't followed up with them. I wonder if they have decided to change their mind and move to one single system. There's a, you know, that uncertainty of if they're going to merge also, you know, drives some of these decisions. And I think we're ready for our first polling question.
Thank you. Our first polling question should be appearing on your screen. And I will read it for those of you who may have difficulty reading it. In your experience, how long would it typically take a health system to merge two different instances of an EHR? Select one of the following: less than a year, 1 year, 2 years, or 3 or more years. Again, in your experience, how long would it typically take a health system to merge two different instances of an EHR? Select one of the following: less than a year, 1 year, 2 years, 3 or more years. We see the results coming in. Very good. Let's take a look. Robert, when you see these numbers, what stands out to you?
Well, it's clear people recognize just how much work it is. Seeing the 3 or more years, and I'll say I don't actually know the answer. I don't think this has been studied, but we did hear cases where 3 or more years would have been very much the answer for some of these mergers. So I think, and maybe in some cases it could be done in less than that, but I think this is probably pretty accurate.
Excellent. I'll turn it over back to you, Robert.
So now, even if you're on the same instance of the EHR, there's still more foundational work to do, quite a lot more. And we actually didn't even go into these interviews necessarily probing too much about this, but we asked about priorities, IT-related priorities and strategies, and this came back as a big one. Data standardization. So trying to have the unified data and also unified analytics capabilities across their EHR. So the less advanced ones had data in multiple instances, or even if the same instances, they had variation due to local control. And they even had multiple analytic functions. And we heard cases where these health systems were asking their different systems to basically do the same, come up with the same numbers, and got inconsistent numbers for the same values that they were asking for reporting purposes. So they knew something was wrong. The more advanced systems in this regard, they had the clinical data standardized in one platform, and they had system-wide analytics capabilities, and especially like some of them emphasized that integrating the clinical and financial data was a big goal, and where they really found helpful for making decisions. So I found it fascinating that even as late as 2018, 19, some of these health systems were just beginning to set up analytic departments. They didn't even have like a unified department set up for doing this type of thing. So there's clearly a movement in this where the health systems view that it's beneficial to standardize these as much as data and analytics as much as possible across the health system. That's the view from up top, of course. Like some people might say, like the end users might be frustrated with the changes, but this is what the executives are trying to do. Now, process standardization is another one, and the view was clear that the major benefit of the EHRs is for hardwiring standardized processes. So the less advanced systems had not very many standardized processes, and what I mean by that are things like order sets and clinical pathways and protocols, and mechanisms for closing gaps in care. There was a lot of discussion of managing order sets, guidelines and algorithms and dosing. So the some of the systems were dealing with multiple legacy scheduling systems that weren't interoperable. And when they tried to make changes, they had some cultural resistance. And this, we heard some interesting stories from these health systems where some of them created their health system, invited a whole bunch of physicians to join, and part of their attraction was to say, come and join our health system, you can do whatever you want. And now that they're starting to recognize, you know, a need to respond to, you know, value-based incentives and ACOs and public reporting, and they're realizing actually that's not what they really want. They are trying to change the culture of these health systems, and that's a heavy lift. The more advanced ones had standardized processes that were built right into the EHR that they could monitor, and they had system-wide scheduling systems. The system-wide scheduling systems. Some of them were talking about their efforts. They initially totally decentralized their scheduling systems and had let everyone do what they wanted, and then they realized they were completely incompatible, and then they had to go through all these efforts to take, you know, like more than 1,000 different scheduling codes and try to reconcile them and make it so that they could improve their scheduling system across the board. And they're in the middle of doing that hard work. I'll say when it came to processes, some of the types of specific processes that came up were around blood use, sepsis, C-sections, and oncology. But there were, you know, you name any process you can name it, and there was, you know, some effort to try to think about how to standardize it. Configuring and enhancing the EHRs. That was, you know, they're spending a lot of work on that, usually post-implementation after they set up a new EHR, but even for quite a while afterward. So many of the health systems were spending their time eliminating previous customizations that they did, which is similar to what I was saying before. Like they had highly tailored them to, you know, some idiosyncratic users, and now they wanted to claw back all that and roll all those back and create it more of a common standard. There was this is where, you know, people were looking into best methods for data exchange, and some of them had very little ability to monitor, or were just beginning to think about monitoring EHR usage, so how well the clinicians are actually using the EHR efficiently. There are some built-in EHR tools to do this, and some of them were just barely, you know, starting to use that. Others were had been doing this for a long time and were, you know, very much optimizing the EHR, like had this kind of continuously built in. They reached the limits of the EHR and were getting third-party tools to help address some of those. They were participating in any data exchange effort they could, and they were doing a lot of monitoring to try to identify problems. So, like, you know, here's one from one of the more advanced systems in this area saying we monitor the hell out of it when we see a physician that has lower scores than we would expect. We go and talk with that physician to understand the barriers. So they have a kind of built-in culture of improving using the EHR to enhance. To continually tweak the EHR and configure it to enhance care. I'm not going to say too much about cybersecurity, but this did come up by quite a number of the executives, the CIOs especially, as something that's on their mind, and had a range of responses. Some were, you know, less confident that they could respond to a threat. Some had invested quite an enormous sum of money into this. And this is, you know, this is a topic in it that could occupy quite a bit of time in and of itself. So you know, but we didn't get in too much depth into this particular issue. So those were the 5 broad categories that we found of the foundational activities that would lay the foundation for enabling care improvement. And I think we have questions. We can we'll address some questions. I'll be going through in the next section the activities that actually did use that, where they're using the IT to improve care, and also the questions about making decisions.
Thank you, Robert. We do have a number of questions that have come in. Let me start with question about how do you balance configuring or enhancing the EHR or EHRs with a desire to standardize processes and leverage industry standards, or the requirements to use industry standards that may require standardization across many EHR and EHR implementations?
So it's a core question. I would say in many ways, the challenges that these health systems were facing was the lack of standards, clear standards for the types of things they were doing. One of the CIOs I remember interviewing and saying, like, there is no body out there that says here's the right workflow for certain, for you name it, or even like here's some options. So they were kind of trying. There's certainly quite a lot of effort trying to adopt standards, the data standards that are being put forward by federal requirements, promoting interoperability. I know you had Mickey Tripathi here a few months ago, and those are clearly helping to standardize things. But in terms of standardizing data, in terms of standardizing processes and setting this up, my sense was from talking to them, they're working kind of on their own and trying to do a lot of stakeholder consensus and trying to do a lot of cultural change. But there wasn't some national standards that were helping them too much figure out how to make these decisions.
Terrific, thank you. Health systems often feel like their EHR should handle all of their health IT needs, including fire, interoperability, price transparency, reporting, etc. Can you speak to the dangers or advantages of that approach and the role that provider organizations need to take on themselves in their health IT?
Yeah, it's a really great question. Where is the boundary? We talked quite a bit about that, and I'll get into some of that a little bit later. But the health systems in general, their approach was try to get as much as they can out of the EHR because they're already spending so much money for it. And in some cases, we talked to I wouldn't say the norm, but some larger health systems were able to actually have the EHR make some tweaks for them. They had to give away their IP for that. They had to say, here, you can have it, but they thought it was worth it so that they could, get what they wanted out of the EHR. But in terms of like where that boundary is, like what the health system should do on their own versus what they should get from the vendor, I think that's a moving target and not at all settled right now. My sense is, and I'll get into some of this later, but to the extent that the health systems are kind of all trying to do similar things, it doesn't seem to make too much sense for them all to be doing it on their own. And I'll get into some of that later. But I don't know. I wish I could answer that question definitively, but I think that I'm not going to be able to do too much better than that.
Maybe the ONC in the use of 2020 hindsight might have said, perhaps we have an instance of the electronic medical record hosted in the cloud and multiple providers can use it, but you start with what you start with and you end up following that trail, I think is where we found ourselves. Thank you for that. I have some other questions here. Do you have any thoughts on how to overcome internal silos on both the data and process perspectives? We find that one of the barriers is that the left hand of the organization often doesn't know what the right hand is doing, particularly in large integrated health systems.
Yeah, we heard that all over the place. It's a major challenge. That is where, and I'll be talking about this a little bit a little bit later, is the question of making decisions and data governance. So a lot of those issues, the left hand not knowing what the right hand could be doing, having a very solid, defined, clear data governance process, not just data governance, IT governance processes on how to make decisions and who makes those decisions and how the money will be allocated, and make that very clear cut. I think is probably the only feasible way to try to address that problem. And it's not going to fix it completely. So we heard about a lot of health systems that would create these ad hoc committees to do things. And then they realized, okay, maybe we should not have everything just ad hoc. Let's actually create some systems to do it. And many of the health systems we talked to were struggling with that, but not all. Some had their, at least based on interviews with the C-suite, they could describe their very strict process, and they had to say no to a good number of, requests that people would come and they say, I want this. And they say, we don't have the resources, can't be a priority. We'll have to look at it next year. So it's a huge challenge, and especially as the systems get bigger and then they absorb, like, they merge with another hospital, and then you have to merge that new hospital or health the provider organization into the decision-making process. You can see, these aren't technical problems. These are human work, governance issues, and they take time.
Thank you. This question is one that we think a lot about at MHDC, and we've talked a lot about in a number of the initiatives we're undertaking, and you addressed at the onset. Do you have any thoughts on why healthcare is so much slower at adopting new technologies than most other industries?
Yeah. So based on, and we're again kind of jumping ahead, which is totally fine, but I think two factors really kind of jump out. One is especially in the US, our very fragmented healthcare delivery system, where we don't have we don't have much centralization where we can make decisions and roll things out. Instead, we have lots of different, 5,000 health systems, and then many other organizations who all have to make these individual decisions and keep up on things and learn things. I think that's one reason, but can't ignore the problem of incentives. So I was thinking, the definition of performance in in communications is essentially, can you have like a video call for reasonably good quality and not have to pay much for it? Like, it's kind of, that's the definition of performance, perhaps. Whereas in healthcare, we have these definitions of performance that relate to quality of care that is very hard to measure and measure comprehensively, at least. The measuring outcomes also and assigning incentives for who is responsible for it is very tricky. I would say those are probably the two, in my view, the two biggest reasons why things are so slow.
All right, thank you, Robert. We will address more of the audience's questions at the end of today's program, but for now, I'm going to turn the program back over to you so that we don't predict any future issues that you're going to be raising in the subsequent slides. So thank you for your answers to the questions that we've asked thus far.
Sure thing. Looking forward to more questions later on. So then moving on to, like, once you get the foundation laid, what can you actually do to create value and to improve performance? So we found here, another 5 activities. So actually using the data and analytics and providing the feedback, improving uptake of evidence-based medicine, so moving it from research into practice, or guidelines into actual implementation. Identifying and reducing variation in care and overuse was took a major focus of a lot of health systems. Prevention and population health management. And then finally, the more of a nebulous one, which I'll get into, is making care more convenient, interactive for consumers. I'll go into each of these. So analytics. So the efforts to, the ones that hadn't laid the foundation well and were, they were still using manual processes, downloading Excel files and stuff. And they had multiple analytic systems that weren't coordinated, and they were focused essentially on just reporting and doing analytics for what they needed to do, and that's it. So what was required. The more advanced ones had real-time data available right there in the EHR, in the workflow, so they could be helpful to clinicians whenever they needed to. they were constantly developing new dashboards that go beyond the requirements, oftentimes in response to requests. So learning about examples where like say, a cardiologist would put together a pediatric registry for a cardio for heart disease problem, and then decide, well, hey, another physician would see that and say, well, I think we need to do, maybe we can do this for adults or for a different setting, and they get all these requests, and some of the more advanced ones were beginning to pilot the AI and ML tools. I wouldn't say they were, none of them felt like they really got that. They were just kind of in very early stages of experimenting with that and planning. But that was clearly the direction that they were hoping to go. And we can see, like I mentioned this before too, some of the health systems that were able to combine the clinical and financial data to get that's how they were able to really get the full picture of performance. Other types of dashboards, they were looking at peer comparisons, like sometimes analyzing like the length of progress notes to look for opportunities to streamline that, like to create smart phrases and so forth. And many of this was driven by, to some extent, by the reporting requirements, so they had to do this anyway. But it was also driven by the leadership, the culture to try to meet their clinical goals and to understand their performance. Now, uptake of evidence-based medicine. This also we saw health systems that were far more advanced than others. So some of them were basically not doing much of this at all. Like they were relying on basic CDS alerts and not too much more. The more advanced ones had these systematic processes for updating new evidence. Some of them used third-party vendors for this. Others had a series of clinical committees to try to review the evidence and make decisions on them, and then they would hardwire them into the EHR for the care into specific care pathways. And then there were a lot were kind of in between. So this is one observation is that having these defined is not enough, like, because once you define some of these, like some of the protocols, they might not be used at all. So the more advanced systems were able to kind of monitor and see, like, why wasn't this one used? Like, is there a problem with it? Do we need to do some more training? There was, so I think that, yeah, that kind of covers what was going on in this category. In variation across health systems, so the less advanced systems were pretty ad hoc in how they were trying to improve variation or reduce low value care, and encountering some major resistance change. This, I think, is telling about, we were talking a little earlier about the incentive issue, and this is one quote, but I think you'll find this not by no means an isolated case. Like, the imaging operation component in our system has been absolutely unwilling to allow us to do much because they're worried about losing overall profitability. Well, there's the incentive issue. On the other hand, the more advanced systems were able to do data analysis very systematically. So this example said, this quote is from a health system that said, "We have some great examples where we have physicians that were of equal quality but leaving patients in the hospital for an extra day or two and sitting down with them and saying, why is that? You have the same outcomes, but you're spending more." And coming out of those meetings where the physician says, I can easily drop off a day. So just being able to have that conversation is pretty advanced, and they were working closely with their clinicians to redesign these care processes. And once again, for this other purpose, some of the more advanced ones were looking for AI and ML solutions. Just to give another example, like this, one of the systems, they say they would notice that all of a sudden they'd have a doctor who started to order a lot of a certain medication. And like, well, they shouldn't be ordering this medication at all. And they would go look into it and find out that the drug rep just showed up the other day and they were starting to order it. So then they had to go talk to them and explain that. Now, even the ones who had been doing this for years were quick to say, well, we've got a lot of room to go. We're still at the early stages of this and doing this type of monitoring and reducing low value care. So they're, even though they have the systems in place for doing this, there's more to do within their health system. Programs to improve population health included risk prediction and upstream interventions. So this is population health is once they have the basic substrate and foundation, the population health component, we found this was probably more so than even the others. Health systems felt they were just scratching the surface on this. Some of them were not even there yet. They were still working on their foundational aspects, but some were still, they were trying to do some work with identifying high-risk patients and once again, experimenting with some data analytic techniques for risk stratification. There was, I think, a fair amount of dissatisfaction expressed with the available tools that they had for doing this well, or knowing that they were doing it well. We, I think, read a lot about these types of interventions, but in the health systems, from the executive point of view, this is very early days in terms of this type of work, the prevention and population health, and trying to intervene before the patients have issues. Consumerism. So this is the last category here for this bucket. The executives were pretty much, just about all of them we talked to were making major efforts to try to make care more convenient and do this consumerism thing, but weren't always really sure what to do. So there was some clear divisions of less advanced and more advanced. So some had multiple patient portals with minimal use. Others had, most of the patients using patient portals. I suspect after the pandemic, this has changed. People focused on this more. Some were just basically doing the portal solely for meaningful use. Others were experimenting. The more advanced ones were experimenting with all kinds of things to try to engage the patients and integrate third-party apps. Now, what's interesting about this consumerism is that the motivations were really, like, the executives weren't always really sure why they were doing it. So in the short term, there was some concern in some cases about competition, like they wanted to make sure they were competing with neighboring health systems. But in the long term, there was a little fear also of, like, third-party entrants coming in somehow. This kind of a vague threat of, like, some high-tech company coming in and making care really convenient. And also, like, the growth of high deductible health plans. They thought patients would factor in the convenience for those types of, if they had those type of plans. But more so, the impression that came across was that they thought there was just a general patient belief that patients would expect this more. And even, some were driving it because they just had a vision and wanted to do this. But others confessed that they were doing it mainly because they were just trying to get ahead of the curve, was one said, or just because everyone else was doing it, and they weren't sure what the business requirements were. They weren't really sure how to do it well, so they were just kind of like, essentially trying to do what everyone else was doing. So you can imagine, like, think about again the back to the other industries. I suspect the people, the telecom provider, the people who are providing video, like software for enabling video calls or internet service, I don't think it was, getting ahead of the curve that was driving that. They had real business reasons, like, to try to, improve that, competition and stuff. Whereas that doesn't seem to be the case in healthcare as the main driver for making care more convenient. It's relying more on getting ahead of the curve, or just the belief that this is the right way to go. So those were the 5 general activities we found for using the IT to improve performance. And then I'm now going to go to the last bucket, which is setting up, which is making decisions about IT. And these are complex organizations, and they have a lot of IT systems in places. Not just the EHR. Some of them have hundreds of other systems, many of which are legacy systems that they're trying to sunset. But they, constantly have to make decisions about these, and we found that they fall into a few different buckets: setting up governance practices, integrating the IT staff in decision making, and working with vendors. and I'll go through each of those. So the governance, there was a clear, it was clear that it was the executives viewed that it was better to have centralized decision making rather than decentralized, where they had multiple ad hoc committees. So yeah, you can see this quote from one of the systems that struggled with this quite a bit. Even though the structure didn't exist, I created it for this process. We actually really pushed that we needed a physician advisory committee to assess and represent the other 600 plus physicians. That was all ad hoc. Nothing was in place. We have to structure and define it. So if you have to structure and define a governance process for every single new IT related decision that pops up, it is a lot of effort, and then doesn't benefit when you have to make the next decision. I'll just add anecdotally, I've looked a little bit in the literature, in the academic literature on this, and I didn't see much published on governance best practices or research into health IT governance decisions. It seems somehow to have escaped the research realm. Maybe it's being covered more in the industry societies, but there's not too much rigorous research that I've found. If other people know about this, I'd be interested in the discussion to learn more. Some systems clearly had this down. They had clear places. It was all centralized. There was no ambiguity. This was a quote: "I have in place a whole prioritization process against available IS resources that operators then select projects to be completed. Then the governance process prioritizes the projects and picks those that match our capability to get them done." And we talked to several organizations that seem to have pretty clear processes, but most systems were somewhere in the middle. They were still had some ad hoc processes that they were still trying to work on. Now, integrating IT into decision making. That was a clearly that's better for more, if you're more advanced in this bucket, you involve IT in the decision making rather than doing what some describe, where they just make decisions and just throw it over the fence to IT and then find out that it is not feasible, and then it causes all kinds of mess. So there were some of them, I think in many cases, they were learning this the hard way, making lots of mistakes, and the opposite was true too. Sometimes the IT group would roll out a new software update, and they wouldn't include much end user input or testing, which happens I know from many experiences that this happens all the time. There's a lot of literature on this, but it was clear that this happened from talking to the health systems we talked to. Now, the more advanced ones, they have a process where they can get input from all these stakeholders as part of the decision-making process, and work together in that regard. Relationship with vendors. We saw the range from some who had almost no influence with the vendor, and when they had an issue, they couldn't do very much about it, and it was a major problem, to others, not just the giant systems, but several systems who had very good relationship with vendors, and had some vendors essentially that they pretty much consider part of their staff because they were on site all the time and made adjustments when they were needed. So this is again, the vendor relationships is something that I think people have talked about in a vague way, but haven't seen too much of this described in any kind of rigorous way or best practices. Haven't seen too much of this. I think that health systems are trying to feel their way through this. And those were the three big activities in terms of decision making. Now I'm going to, so that was kind of most of the main findings from our study. And there's limitations, of course. We only talked to the executives, we didn't talk to the end users. But I think we at least got kind of the big picture from where the executives were trying to head in terms of how they were trying to improve their performance with IT. So a few takeaways, and then I have a few thoughts on what could be done to move things forward. So it's clear that we're still at early stages of this process. So these kind of big complex organizations have been doing things their way for a while, and the technology is offering opportunities to do things quite a bit different. And so it requires not just changes to the technology, which it's going to require quite a bit of continuous changes, but how these the organizational processes work, like what people actually do, both in terms of management and in terms of what clinical care really means, and then also what the organizational culture is. Like, we heard quite a bit that people didn't want to change. Like, that's no surprise probably, but to actually have this kind of catalyst, to use IT as a catalyst, all these are probably going to have to change quite a bit. Another finding is that so data and process standardization. So that's not something we were necessarily probing too much at the beginning, but that we learned there was so much discussion of data and process standardization that in these 24 health systems, each one of these categories, data and process, had about 200 pages of single space, small font text that we coded up because they were spending so much effort on doing this. The reason they were doing it is because it enables things like what's on this slide. So you have that you can more easily move evidence into practice. It's extremely hard to move evidence into practice when you don't have, when you have to do it in different ways across the health system, and have, put it into multiple different workflows, or use map to different data standards. And you can't even identify the variation, let alone think about strategies for reducing it if your data is not uniform to some extent. And then we're relying on population health initiatives again, like trying to even identify the patients who would be good candidates for this if your data is not at least somewhat standardized and have similar meetings, and you don't have a way to do this into the workflow. It makes it extremely hard. So one thought here is that health systems, they might need some help in like some direct help in doing this. So yes, moving the incentives in the right direction can be helpful, but there's so much redundant effort that we learned about. Like, the health systems are trying to do the same thing. I thought it was particularly interesting when we talked to some very large health systems with multiple hospitals, dozens of hospitals, and they're very committed to kind of creating like single standard practice model, so that when the patient comes from whatever hospital, whatever clinic, they see that the shingle, they see the name of the health system, that they'll expect a certain experience. And these giant health systems are determined to make that happen. And if that's true, like, one asks the question, well, maybe there's some best practices that are more broad than just that health system. Maybe there's some more universal best practices and lessons that can be done. So one thought is that even though, like, many of the federal efforts, initiatives such as promoting interoperability and changing incentives, which are maybe not happening as fast as we would like, but even so, like, that may not be enough because of these process issues and these need to and standardization and data issues in order to enable that next level of innovation. So a few other final thoughts is maybe these health systems could learn from each other, like maybe some more detailed case studies or best practices. We could be diffusing knowledge on approaches that work and don't work. There's a lot of area for more investigation in this front, I believe. And then the data and process standardization. I mean, that is, it's not just to be able to do, in addition to doing the type of things I'm doing, like the part of the purpose of doing this, not just in the health system but also on the national level, is that it would facilitate innovation, in the sense that you'd be able to create a new app and distribute it much more easily. That's people talk about that a lot in terms of data, but processes, like it's not easy to install a new app into such a fragmented, wildly diverse clinical processes. So I think the national goals of trying to standardize data and the health system goals of trying to standardize data and process very much synergistic, and have the potential to feed off of each other, and maybe could inform each other's efforts to some extent. And then I'll end with this quote from Atul Gawande, which I think puts this in a larger perspective than just the IT part of it. And this is more than 10 years old, but it's still very much true, I think. And this is from his commencement address. And he says, making systems work in healthcare, shifting from corralling cowboys to producing pit crews, is the greatest task of your and my generation of clinician scientists. And I think that gets at, right, you can only, IT can be only so helpful to a cowboy, right? That's, they call it paving the cow path, right? Whereas if we're, so this is not just the story of IT, I think, is what we're seeing in these health systems. It's the story of these systems trying to work together systematically to improve care, improve their performance, improve all these the larger goals of the healthcare system. And that means, like working closely together and knowing the process and having things work well with each other. I think if we keep that in mind, that the IT is, enabler of making this transition, then we'll have a good chance of making some good progress. I think we have a polling question now.
We do have a polling question coming up. Thank you, Robert. Our second polling question should be appearing on your screen, and it reads as follows. What stakeholder is best positioned to facilitate the sharing of IT-related best practices between health systems? Is it the federal government, state governments, HIT vendors, private payers, public payers? Again, I want to read this so folks can understand it as best as possible. What stakeholder is best positioned to facilitate the sharing of IT-related best practices between health systems? Is it the federal government, state government, HIT vendors, private payers, public payers? We're watching the results come in now. We're seeing some interesting findings already. Thank you for participating in the poll. We appreciate your insights as we near the end. And with that, we're going to close the poll. And Robert, we have some interesting responses. We have 43% of our audience members saying the federal government is best positioned to facilitate the sharing of IT-related best practices, followed not too closely, but within eyesight, state government, and then further back, HIT vendors and public payers. Would you care to comment on these results? Give us your thoughts.
I think this is pretty interesting. I will say and we only allow people to choose one, so they chose, the one that's best positioned. So clearly the government, federal or state, is, this audience thinks that that's a big part of the solution to help with this. What's most interesting about that is those are not the stakeholders who are really taking a huge lead in this. Not to say they're absent. I mean, AHRQ funded this study, right? But for the most part, that's not the stakeholder that's currently most responsible for doing it. It's really, I think people are mostly relying on the health IT vendors for doing this. So it sounds like this audience thinks that there's, an opportunity for some more facilitation by the government to spread some of these, develop or spread some of these best practices. Which I think that's what we heard from maybe they've believed my presentation, believed that kind of viewpoint. But I would be particularly interested in anyone who chose HIT vendors and also public payers to kind of elaborate a little bit on what they could be doing different. My only thought is, like, right now, one option is to say, well, maybe we should just leave the system alone from a policy perspective and let let the market keep playing out, and it's going to go as fast as it goes. So I mean, maybe the people who chose HIT vendor, maybe that's what they think. Like, they're doing a good enough job. It takes time, and if the government tries to do anything, it won't be able to help. I'd love to hear that argument fleshed out.
Very good. All right. So thank you for everyone's participation in our poll. Just a quick reminder to our audience, if you do have questions, please enter them into the questions pane, and we will answer as many as we can in the time that we have. So let me start, Robert, with a question that crosses our transom more today than ever before, which is that health equity is a big priority for healthcare. Can you address how health IT improves performance in this area?
So, that wasn't part of this particular study. So I'm going to kind of
we're going to ask you to go off script and give us your perspective on this.
Absolutely. So my sense is that currently there's, appropriately a large effort to try to address health equity issues. But just like the results I just presented, they're fragmented. Every health system's kind of on their own. There's no playbook to do that. At least, I mean, I haven't seen a clear playbook. Maybe it's a little early in some sense, but in terms of how to use the health IT to do that, we have seen some high-profile examples of what not to do, like some problems with like algorithmic bias, and there is an enormous amount of NIH investment going into investigating this problem, looking at data and algorithms. So maybe it's kind of too early, but in terms of you're a health system and you want to address equity concerns, and you want to do it in a way, you want to leverage your tools as best you can to do that. I haven't seen any clear best practices. So I think this is another case where the fragmentation and lack of someone kind of coordinating and coming up with some best practices for this, or helping to curate the information out there, is leaving the institutions kind of on their own to figure it out, which is probably not the most efficient way to do it.
I think that's well said. We're seeing, considerable heterogeneity or differences among different organizations' attempts to deal with this issue. And this leads a little bit into one of my next questions is, the poll that we put up on facilitating sharing of data didn't list organizations or groups like the Da Vinci Project or WEDI or standard setting organizations, accelerators. Could you speak to their role and how much you think they might act as this normalizing influence that may spare some health systems having to figure this out on their own?
So absolutely. So one thing I really like about, to reference again, when Mickey Tripathi came and spoke to you, is he mentioned right now the regulations are trying to free all the data for the patient's access, but one of the main purpose of that is just we know that the data standardization process is slow. Making these federal universal standards for data is not as they try to make global standards, big consensus standards, and it takes a while. So we don't want to wait for all of that to happen. So but I mean absolutely, if you can get to the place where you have a global standard, and the accelerator programs are great examples of that, to the extent we can systematize that even more and help with implementing that. I know HL7 has started a standards implementation division, which is just getting going, and that might help with that. It absolutely could play a role. So to the extent that the health systems can just focus on there is a well-defined standard, then and an implementation guide, that could help them internally too. Even when there's a well-defined standards implementation guide, there's still likely more wiggle room than any of us would like in terms of the actual, data that ends up being there and how the clinicians use it in some cases. So I don't think the health systems work. It's not going to it's going to help, but it won't completely solve the problem.
Thank you. Yeah, we think it's a necessary but insufficient step. We have to go from setting standards to from cookbook to test kitchen to implementation, and provide as much guidance as we can to the health data community, which is growing by the day as patients become more and more engaged in what's going on with their healthcare and more a part of the health data economy. Can you talk about the role of health monitoring and personal health devices in data issues and how they might fit into the picture that you've described in your presentation?
Yeah, so that I would put under this bucket of consumerism. To some extent, you could put them in the bucket of consumerism. The health systems right now, and I think in general, don't really know what to do about them. Like some active patients are driving that, but in my view, what would make that go from right now, like kind of experimentation, to something that would make a difference would be clear, defined, clinically integrated interventions for how they can be used. So, if you have some kind of device that has a monitoring system, we need more than just a device and just like an alert that goes to the clinician. We need to know what the roles are for the clinicians, the optimal roles are. We need to have some sense of what the burden is on the health system and the clinicians that they can expect to get if they adopt this. We need to know strategies for how to keep the patients engaged, what to do. It's more than just the device. It's a whole intervention with the workflows bundled together. Other than this research, I spend a lot of time thinking about developing such clinically integrated interventions. But until we have something like that, and I don't know if we have a great mechanism for developing those. This is, once again, we're kind of relying on the vendors for doing that, and hopefully they'll work closely with the health systems and figure that out. But it's a painful process to go through every single health system and kind of adopt that. And some are doing that and able to be successful. But it's kind of a slow, let 1,000 flowers bloom approach, which is maybe good for early stage innovation. But at some point, I think would be more efficient and helpful to have some pathway to go from the let 1,000 flowers bloom approach to like picking the flowers that actually help in developing them and helping move them on a glide path towards scalability.
Thank you. You mentioned that reducing variation in care is a way to improve performance. But the flip side of this is that patients are different and variation in care is often medically appropriate. How do you make sure a goal of reducing variation doesn't adversely affect care quality?
Oh yeah, very true. So I'm not a clinician, so I'm not going to speak to any specific clinical aspect of this. But I will say that the current efforts that we talk to for the health systems to reduce variation in care, we're trying to they were first trying to reduce like clearly defined low value care, such as like the Choosing Wisely campaign. So things where there's at least some clear consensus that or clinical consensus backed by studies that show that certain things are not helpful and might actually be harmful for patients. So there's a large category of that I think is maybe less of a concern for the particular question raised. But then there's also this question of like, I think the key issue that the health systems are concerned about is, well, to a single patient getting different treatment in different places, and the only thing that's different is just it's a different clinician. So if it was really tailored to the patient, and then absolutely, like that's what we want. But if it's different because of some idiosyncratic preferences, or someone's used to doing things a certain way, well, from a patient perspective, that's something that I think people would want, the patients would want. Well, the health system should get together, figure out what the right approaches for patients like me and implement it, rather than having this variation. So, this is a long history. This is, that the Dartmouth studies have documented all this variation for quite a while. But the health IT can help identify these and flag these and target and maybe inform where the conversation should happen and say, well, like we have such a huge variation in so-and-so order set or so-and-so protocol or use of whatever medication, and track those and facilitate the conversation. Of course, it can't solve the problem. Like that has to be punted to the, not punted, but has to be developed in concert with the clinical teams, in an integrated fashion. But ultimately, it's really the clinical teams that have to make those determinations.
Okay, thank you. Do you have any recommendations or thoughts on what smaller provider organizations with fewer resources can realistically do versus the larger systems that were the basis of your study?
Such a good question. I've been thinking about that quite a bit, because there is there's some advantages to being small, right? Like, you don't have to have a big governance structure, or you can make decisions quickly. There's some downsides though. You don't have the resources to be able to invest in these big programs. You need to get full data on your patients. You really are dependent on working with other organizations and collecting the data together. So I do think there's, for some forward-looking organizations, there's they can certainly do some innovative things, if they're small, because they can be pretty agile. But I think they're going to always kind of come up against this like problem of, well, partly they're going to come up with this problem of like, if they want to incur risk, like they just won't have won't be able to do that in terms of financial risk because they won't have the patient volume. But in terms of an IT perspective, until or unless the industry gets to the point where they can they can have, I don't know if outsource is the right word, but probably outsource like a good portion of their IT systems, and then it's going to be hard to do. I think it's going to be hard to do a lot of this, kind of cutting edge innovation stuff. Like, identifying variation care doesn't even make sense for a smaller group like that. Like we don't have that many providers. And doing population health initiatives, like, that there's a certain fixed cost to be able to set some of those up. But not all of them. There might be some ones that are, more scalable that don't play out. So I think we're in early days, and there's going to be some interventions and some things that you can do for a while. But then I think that a lot of them are going to kind of hit a wall, and I think this consolidation is going to keep happening. But after that, it's possible that there might, in the future, as is, shown in some other industries, they might be able to like kind of be like associated with a larger health system, but also do some more experimentation on top of their platform, and have some degree of autonomy. I think that could happen kind of down the road. You'll have some health systems who might say, well, we'll give you the IT platform and allow you to do all this other stuff, but we're going to give you a lot of autonomy to manage different things. So some interesting case studies of how 7-Elevens work in Asia, where like they make all kinds of decisions on their own, very autonomously, based to target, highly tailored to their specific location. And it's possible, I hope the health IT will eventually get that modular and configurable, but I think we're not in that phase yet for the most part. We're more in the kind of consolidation and standardization phase.
And certainly just the cost of entry, the capital costs required to be a healthcare provider now have gone up considerably with these technologies, making it harder for many of the smaller organizations to do some of these things without, as you point out, some collaborative. This isn't a plug for MHDC. I just can't help myself. But without some help or some support to bring that community together and figure out how they share what are costs and investments that are too onerous for a single organization to take up on their own.
Yeah, I think that's right. And there was one of the health systems in this study or two health systems were really fascinating. They were these two distinct health systems, totally organizationally independent, but they actually came to some kind of agreement and shared the same EHR instance, like completely shared. So the functionality was the same. They had a separate like kind of service area, so they could configure it, and they had their own decision support and everything. But they managed to figure out the governance. And one of the executives said that if someone came to him and said, described it, he wouldn't have believed that it would work. But somehow it works. They don't compete, they just collaborate. But yeah, and the main driver for that was, rather than having to set up a separate instance, which wouldn't have been financially possible for this health system, now they can just share the same instance and share the resources. So that, I think that's one example of maybe an early example of how some of these type of arrangements might happen.
I agree. We have an interesting question here with respect to the needs or concerns of federally qualified health centers or community health centers. Are there specific needs or concerns that these organizations have that differ from the health systems that you looked at? Or did you include any community health centers or FQHCs in your study, or as part of some of the integrated networks that you interviewed?
It's a good question. You know what? I'd have to go back and look. I actually don't recall off the top of my head, but I'm pretty sure the answer is yes. We definitely had some like low resource settings, and I'm pretty sure they were FQHCs, but I'm not 100% sure. In terms of the needs that are different, I think they're pretty similar actually to the other ones, except that they're they have fewer resources. But in terms of like what their requirements are and the type of what they need to do in terms of laying the foundation and the type of work, my initial reaction would be, I think they're going to have some of these same challenges and would benefit from some of the same solutions that any other healthcare system would experience.
We've seen some examples of collaborations among FQHCs and in hosting, sharing a common instance of Epic and being able to, or a common instance of another EHR provider, to lower the per facility or the per clinic costs, and to enable them to have the same level of technology as some of the bigger players do. In your work, did you look at the IT needs around specialized data like images, genetic testing results, or things like behavioral health and substance abuse that have different requirements in the regulations that come with a whole host of different rules and requirements?
In this study, we did not. It would be interesting to look at all of those. Some of them did, the executives did mention some of the challenges with imaging and everything, but no, that wasn't the main. That wasn't the main focus of this, and we didn't look at that systematically.
All right, let's look at some of your findings. Can you pinpoint some areas within your findings that you think were particularly changed by the pandemic?
Yeah. So definitely the whole consumerism thing, I think likely, whereas before it was this consumerism thing was this kind of nice to have, maybe they prioritized it, try to get ahead of their, of some competitors. And then overnight it became an absolute necessity. And also, there was money behind it, they could actually reimburse for it. So that changed the equation. Now that for the pandemic, that became a foundational requirement of just operating the business. Now, in terms of anything else, I'm actually not sure there's any other, but that's a big one. Now, a lot of my colleagues studied this quite extensively, and at RAND and other places, and there's a lot of effort to try to track what's going on and also try to see if it's going to be sustained and discuss whether it should be paid for the same way or not. There's some ongoing debates on that. One thing that I do think is just transitioning to virtual in terms of like having access to virtual care. While that is a big deal, it's still not. It's still basically doing what we're doing, but remote. So it saves the time from going into the office. If you can save that time, which is always nice to have that convenient. But it doesn't really radically change the way care is delivered. So I don't think I wouldn't consider those changes to be like population health initiatives, or like it's still a matter of like you have your regular visits, or you have an issue and you go to the doctor, or chronic care patient, you have you're managing your symptoms, but you're not given. It's not like that instantly gives you any extra tools. Those interventions are still being developed and could use a lot more development. There was some interesting innovations as part of that have been published or will be published, where people have adapted or created new interventions to, like, say, monitor symptoms of COVID-19 or something like that. And in some of my other work, we had an asthma symptom monitoring study where we have this symptom monitoring app. And when the pandemic hit, we were able to get some supplemental funding to build a COVID-19 screener into the app right there. So that's, basically, rather than having patients remember to go use a screener, like, they're using an app every week, when, we kind of remind them and nudge them to, use the screener. It's right there in their workflow. So, I mean, that's just one small example of where I think, if we could be doing quite a bit more than just, a virtual visit instead of an in-person visit.
Thank you. Are there specific quality measures you'd like to see to help track the role of health IT and system performance? What would we look at? What would we be looking for?
Yeah, gosh, what a great question. We could brainstorm quite a bit on that. I really hope we get beyond like use of functionality, like minimal use of tools, even though that still could play a role. But I mean, there's always going to be a little bit of that, I think. Yeah, I mean, the question really is kind of what are the IT sensitive measures, or like the quality measures that are sensitive to, like, IT related innovation. There's been a look at that, but it was a while ago that the study I'm looking at. I think it might be time for a refresh. I think in addition, maybe, so I was talking about like IT enabled interventions, like that's really, I think, what would be a good way to think about measurement going forward. It's like when you have like a specific intervention and you can measure like use of that intervention by the patients and the providers, and incorporating that, I think there's a lot more opportunity to incorporate patient input into those measures. So patient reported outcomes, like they're collecting those more and more, but I don't think they're collecting it very much like longitudinally between visits. And that's great data to be potentially used for quality measures. So that's one area which I think could be investigated quite a bit more.
Okay, we're nearing the bottom of the hour, and we have a number of questions, but I'm going to ask one more quick question, and then we're going to take the questions that we're unable to get to and follow up with you, Robert, about those remaining questions and make those answers available on our website. So let me just throw one here at you that's kind of near and dear to technologists' hearts. Do you have any thoughts on how to improve the understanding of AI, artificial intelligence, and how to use it sensibly and equitably at the provider level? Does regulation have a role to play in improving this?
Yeah, this is a huge area and very new. And I wouldn't say I'm certainly not an expert in this area, but I know a little bit about it. And I think absolutely, I think we need a lot more innovation in the space to be able to make sure that we're using it equitably and fairly. And are we ready for regulation? I think if people start to use it, and then I think that's probably the time to think more about regulating it. But I wouldn't say I'm really confident in that I have the solution for that yet. I think we're just in such early days that it needs a lot more kind of analysis.
All right. Thank you very much for sharing your expertise and insight with us, Robert. There are a number of additional questions, but I also know everybody who has joined us today has their calendars full, and the opportunity to get a half an hour back from a 2-hour time might be a good thing for everybody to get a fresh cup of coffee and to prepare for the next item on their schedule. But I would like to thank Robert Rudin for sharing your experience and insights with us. And I'd also like to thank everyone in the audience for setting aside time to participate. Before you leave, we know you're all busy, but we would really appreciate your taking a minute to give us your feedback by completing the electronic survey that you'll see upon exiting today's webinar, including any topics that you would like us to present in the future. We hope you will enjoy our future seminars. We hope you will be joining us for upcoming programs in the MHDC webinar series. Please come to mahealthdata.org for more details and register for future sessions and look for our upcoming event emails. Thank you all and have a great day.